Good evening, good afternoon, everyone. My name is Cliff Hoyt. I am the VP of Scientific Affairs here at Akoya. It is my pleasure to introduce our guest speaker tonight, Dr. Alexander Borowsky, fondly known by all as Sandy. For a bit of a formal introduction, Dr. Borowsky is a surgical and molecular pathologist with expertise in cancer diagnostics and model systems for cancer research. His research is primarily focused on human breast cancer and mouse models for this disease. He has extensive experience in many aspects of experimental pathology and animal models of human disease. Specific areas of interest include the tumor microenvironment, precancer progression, cancer stem cell origins, cancer-promoting microenvironments, and the regulation of progression and reversion. On the less formal side, I would like to say that working with Sandy has been a delight, mainly because of his enthusiasm, good humor, intellect, understanding of pathology and clinical needs, and his drive to advance biomarker methods for the benefit of patients. We have been collaborating now for many years, starting when we just launched our multiplexed IF platform. Sandy was one of the first physician researchers to recognize the importance of retaining the spatial information related to cellular interactions in the microenvironment. After all, it is in the microenvironment where immunobiology allows progression or drives response. The only way to shed light on it is to image at high resolution with multiple markers all at once to reveal multiple cell types and functional states. Sandy has been involved in multiplexed immunohistochemistry for some time. He helped Gary Nolan, a founder of Akoya, on the development of MIBI. And then after that, Gary, as many of you know, went on to develop Codex, which is one of Akoya's core platforms. Sandy's focus today is developing methods for clinical practice, which is why he and his team have made Akoya's phenotypes platform a main component of their work. He and his team have developed a number of panels that may form the basis of future lab-developed tests in his lab with direct predictive therapeutic implications. In his talk, Sandy will share preliminary results of work focusing on high-risk invasive breast cancer and high-risk non-invasive ductal carcinoma in situ, DCIS, hypothesizing that immune evasion might be one of the critical steps in progression of DCIS to invasive carcinoma. Thanks very much, Sandy, for agreeing to talk in our workshop. Please, everyone, join me in welcoming Sandy.
Thanks so much, Cliff. Thanks for inviting me, and thanks to the rest of Akoya for inviting me. It's a pleasure to speak with you all today and go over sort of my thought process on how we approach this difficult and complex issue of evaluating the tumor immune microenvironment for better treatment for our patients. So just a couple of disclosures. Akoya has been a great partnership, and they've given us a lot of help along the way, but they don't directly pay me as a consultant or any other way. And then similarly, I've benefited from other collaborations, but these are all research funding collaborations, so I have no further disclosures. My objectives today, if I can get through all of them, are the following, and hopefully we'll get through at least 2 or 3 of these today in the time allotted. So I don't need to tell this audience anything about this. Immuno-oncology has come a long way, and evaluation of the tumor immune microenvironment as a predictive biomarker for outcome dates back way back, but got really renewed life in 2006 with this Jerome Galan paper on colon cancer showing very good stratification based simply on the measurement of the macrophages and CD8 cells primarily in and around the colon cancer. The NCI about that time, 2006, was working on this so-called match trial with the concept that instead of treating each individual cancer like it were a different disease, we should treat cancers that have common oncogenic drivers in similar ways, especially as our armamentarium for oncogene-specific therapies grows. and we should apply those across different organ site cancers, regardless of the site of origin, but based on the oncogene that we detect through sequencing and mutational analysis. And so this dates back to sort of the subway map that Doug Hanahan and Bob Weinberg published in about the year 2000. Cell intrinsic kind of idea where there were multiple ways for the epithelial cell to adopt different oncogenic mutations and permutations to get to transformation. After publishing this, Bob Weinberg and others heard from myself and a lot of other people, my mentor, Mina Bissell, saying, you're missing a big part of the picture. And they had to admit that was true, that it's not all about the epithelial cell, but instead, you have to consider all these myriad effects that are part of the host and the host response, including, of course, this avoiding immune destruction and emerging, at the time, emerging knowledge that there was also tumor-promoting inflammation. So the inflammatory cells were both attacking the tumor, and tumors were evading it, and the inflammatory cells were also creating a more tumor-permissive microenvironment. And so these things were important. So as they revised their hallmarks of cancer, we began to look in and around the tumors at these cells. And this is just the simplified version of some of the cells that you see in and around tumors that we're all measuring very carefully these days. Around the same time, you guys know this story very well, the PD-1, PD-L1 checkpoint inhibitors came out. I like this cartoon because it's nice and simple. It just says we're blocking the ability for the cancer cell to tell this T. When we do that, some of you remember Jimmy Carter, who had melanoma metastatic to his brain, was able to eradicate completely that tumor, even though it was in the central nervous system, and even though in many cases that would be lethal disease, he was able to be cancer-free using this new immuno-oncology therapy. Unfortunately, PD-1, PD-L1 checkpoint inhibitors really show only a complete response in only a minority of tumors, with partial responses seen, but we sort of have this need then to figure out who really will benefit. So we have some biomarkers to select for patients that are more likely to benefit. But we also want to find ways to improve on these PD-1, PD-L1 checkpoint inhibitors. And so story number one that I'm going to tell you today involves one of our mouse models, because we used the mouse model in preclinical studies to try and determine how we might do a better job of allowing the PD-L1, PD-1 to work. So early in my career, I recognized that the mouse models that many people were using, many of which were xenografts of human cell lines, were not optimal, certainly not optimal for immunotherapy studies. And we started developing what we call syngeneic mouse mammary carcinoma cell lines. These are cell lines that can be transplanted back into the uniform strain background that they started in, and therefore you don't get rejection, but you do have the potential for immune reaction to those tumor cells. And a more recent one that we published just in 2018 uses an ERB2 mammary cancer model, and this, very interestingly, is the only mammary cancer model that I know of that actually the tumor cells express some PD-L1. So this became the ideal model for us to try and develop improved methods for treating HER2-positive breast cancers with immuno-oncology. And what we learned in our studies was interesting. So first of all, we learned that that PD-1 blockade by itself was not as effective as we'd like. It was sort of effective if you were treating the primary site, and here we're treating the primary site with an adjuvant, a toll-like receptor agonist, CpG oligodeoxynucleotides, and then giving systemic anti-PD-1. And so we wondered if we could improve on this. And so what we discovered is that priming, so-called, is an important component of this treatment. So we added a priming step followed by an ablation step. With the ablation step, the idea is then to have the tumor itself serve as its own vaccine. And then in the animal model, you can ablate the primary tumor. You can even ablate a second primary tumor and have yet another third primary tumor that you don't ablate, and see what the effect is in the so-called abscopal site. And using this protocol, we were able to show extremely good outcomes, extremely good treatment, even of that untreated site. So that's exactly what you want to do in patients that might have metastases that are not approachable. It's this auto-vaccination. And this was work done in collaboration with Kathy Ferrara, who's now at Stanford, and really exciting stuff that we continue to work on. Meanwhile, about the same time, I was starting to work with this group, the National Cancer Institute MCL Consortium. MCL is the short version, stands for Molecular and Cellular Characterization of Screen-Detected Lesions. And so more and more it's becoming recognized that when we do cancer screening, either for breast, prostate, or now even for lung and pancreas, we're finding disease that we're not sure whether we really need to treat or not. And so this becomes sort of an overdiagnosis problem, and the overdiagnosis problem leads to an overtreatment problem. And so what do I mean by overdiagnosis and overtreatment? Well, when we started doing mammography in the 80s, you can see we began to detect much more breast cancer and much more ductal carcinoma in situ, the precancer in the breast. That should be matched, if all of these were destined to go on to become advanced stage disease, by a decrease in the frequency of distant disease, unless there's actually an increase in disease prevalence in the population for some reason. And some people joke, I think mammograms cause breast cancer. I don't really think that's the case. I think what we're finding are these are lesions that were not destined to progress, and therefore we don't really need to treat them. We can leave them alone if we can just tell the difference between these. There was a decrease in the stage jump from localized to regional disease, but no drop at all in the distant disease. And so how do we think about this, and how do we deal with this? Well, I always like to say, who's to blame for overdiagnosis? If I call it cancer when I look through the microscope and I don't tell you whether this is an indolent, didn't need to be detected cancer, or if this is a cancer that really needs to be detected, then I'm to blame for the overdiagnosis, and I want to do better. So one of the ways I want to do better was to look at the microenvironment around the tumor, with the idea that that was going to be one of the factors that leads to some tumors essentially not evading the immune system, not having an immune contributory component, so having the immune system essentially keeping them in check. And so we adopted this methodology. Cliff alluded to the vector microscope with 7-plex immunostaining panels, so we could get a better idea. And this consortium, so this is what the data looks like when we start to do this. And you can see it's not a trivial exercise. In pathology, we're used to just looking under the microscope. So step one only. But here we're using spectral unmixing. We're using a tissue segmentation, which is based on a machine learning algorithm, then followed by a cell segmentation, so we can record the findings for each cell. Each cell then is phenotyped based on its characteristics with the different fluorescence markers, and phenotype both in the both of the segmented areas, scored in the tumor area, scored in the stromal area. And the end result of this, I should say, not all tumors are alike. So these things vary dramatically from tumor to tumor. And here's just an example of two tumors that I think are interesting. So at the top, you can see there's very high CD8 count and a lower level of FOXP3 T regulatory cells, whereas in the one on the bottom, very low numbers of CD8 cells and much higher levels of FOXP3 T regulatory cells. So that's a very simple example. Of course, this gets much more complicated as we go on. I've learned that T regulatory cells themselves are more complicated than you'd like. There's peripherally induced and centrally induced T regulatory cells. And working with Eric Sebsta, who engineers knockout mice to study immunology, we asked the question, can we engineer this peripheral only, not central Treg depletion? I really like Eric's profile picture on his Wayne State page. You should check it out. But this is Eric's cartoon picture. But he's been able to engineer downregulation of maturation of peripheral Tregs. And then the question is, what happens to tumors? And I won't tell you that answer. That publication is in preparation, but it's super interesting to recognize the importance of T regulatory cells as part of the process of tumors evading immunosurveillance and getting around the immune system. Without those peripheral Tregs, they really can't do it. Meanwhile, back to the human, we decided that we really wanted to study this in the context of breast cancer in the I-SPY trial. And for those of you who don't know the I-SPY trial schema, this is an adaptive clinical trial that's gone through multiple rounds with multiple agents. And there's a trial going on right now that includes pembrolizumab along with paclitaxel, adaptive randomization. This is followed by standard chemotherapy. But the important thing to see here is that we have a core biopsy right up front. We have a core biopsy on therapy. This, to me, is the place where we can best tell whether that pembrolizumab is having an effect. We can see the effect on therapy. And then the endpoint for the I-SPY trial is a pathologic complete response. So that's at the time of surgery, which is, you can see, just 24 weeks later after starting. So we don't have to wait 5 years for outcomes to determine whether or not we had effective therapy. When we do this, we're using, again, the Akoya vector system to evaluate the immune system. We see all of the different patterns that you might expect. And then we're asking which of these patterns do lead to that complete pathologic response with neoadjuvant pembrolizumab and which do not. And so if you look at this, importantly, we're trying to look at T cells in proximity to tumor cells. So we're looking at the spatial proximity, the spatial arrangement. And that's why the tumor immune microenvironment, but also the space is important. And we can look at different cell types and see the correlations very clearly. PD-L1 positive cells along with T cells and cytotoxic T cells. And we can see the pretty dramatic differences, actually. I mean, there's a lot of overlap here. Our numbers are still small and the data is preliminary, but I do think we are beginning to be able to predict which patients are responding, which patients are going to respond prior to even starting the therapy. And here's the outcome data. You can see the ones with the largest p-value versus the smaller p-value. Better p-value is a bigger circle. The ones that are higher in the pathologic complete response, just the number of T cells, also the PD-L1 and the stromal cells and the PD-L1 combined, and so forth, are predictive. Low numbers of the macrophage to T cell ratio, low numbers of macrophage to cytotoxic T cell ratios. And we can go on and look at this in more detail with HER2 plus or minus, HER2 controls, and this has become a big part of what we do. Of course, PD-L1 is not everything. We're seeing that there's ways to drug many of the interactions at the immune synapse. And if we go with the hypothesis that every cancer must evade the immune system, maybe some of them are doing it using some of these other synapse partners. And all of the red words here are all drugs that are either in clinical trials or in the pipeline for therapy. So all of this is a big target for pharma today, and we're growing our list of things that we want to evaluate. So in this panel, here's just a short list of some of the other things that we're testing. All these can be stained and evaluated. These are just tonsil controls, but you can see OX40 versus the T cells. You can see, where'd my mouse go? You can see LAG3 in the tonsil. You can see VISTA or B7H5. B7H3, interesting pattern, more membranous. All of these are going to be important, I think, in evaluating what we do next. I've been calling this the Immuno version of the match trial. If we can figure out which of the immune checkpoints and immune synapse partners are at work in a given person's tumor, just like we did with finding the oncogene that drives that tumor, we can choose our therapy based on that. And I think we're starting to see those kind of trials come into practice. I want to try and finish up in my last 10 minutes or so. Hopefully I'll go fast here with the problem of precancer, the problem of DCIS. And what do we do about DCIS, where we know that many women are treated with surgery and radiation, and yet their outcomes are extremely good, suggesting that this is a real area of an overtreatment problem and that medical therapy for DCIS may be important. And so how do I think about DCIS these days? I won't go through all this history, but the history is fun to think about. Again, this is now from the New England Journal in 2004. My colleagues wrote an editorial describing the state of the art with DCIS, and they put this conceptual framework together, which is the old Hanahan subway map conceptual framework, where sequential acquisition of morphologic changes are accompanied by additional epigenetic and genetic hits, sort of cancer as an evolution hypothesis. And this has really not helped us with this process. We have not found ways to prevent or treat cancer based on this concept the way we'd like. There aren't consistent genetic hits that go from in situ cancer to invasive cancer. All the genetic hits, the oncogene drivers, are already present here at the DCIS stage. So what's controlling that step where you go from so far not lethal disease to potentially lethal disease? We think it's all over here. It's all about microenvironment regulation. And there's all these different possibilities. There may be precancers with long latencies. There may be precancers that arise essentially at the same time as cancers, and there may be cancers that arise without a precancer stage. And of course, there's going to be subtypes of these. When we say breast cancer, we now know that we mean at least 6 or 7 different diseases, not just a single disease. So putting that into context, we've been proposing that DCIS may be an area where the immune system is definitively keeping that in check, providing a tumor suppressive immune microenvironment. And we've been studying that. And so if you look at a series of DCIS cases now that we've been able to profile for their immune microenvironment using these 2 panels, and these are just 2 representative images of these 2 panels, you can see these different categories, some which have high levels of T cells and CD8 cells. Within that group, some of these have high levels of PD-L1, both in the stroma and in the macrophages. Some of them have very low levels of PD-L1, even though they still have these macrophages, and some have neither the PD-L1 or the macrophages. Over here, these DCIS are almost unrecognized by the immune system. So that's another potential for immune evasion, which is simply not to be recognized as non-self, sort of be recognized as self or not present neoantigens. And so maybe those are higher risk for the patient, but maybe they're actually lower risk because maybe these behave much more like normal tissue with less propensity to be invasive. Over here is an interesting group where very little inflammation, but the DCIS itself is expressing that PD-L1 and probably using that to suppress the tumor immune microenvironment. Here, the macrophages have the PD-L1 expression and so forth. We've also been looking at the proximity and proximity analysis of the Tregs to the T cells, how much are they interacting with one another. And when you do this, this immediately starts to become a big data problem. And I won't go through all the categories here, but when you start adding spatial proximity measures, you can see that the situation gets more complicated. But there's still distinct subgroups of DCIS here throughout. In the Precancer Atlas project, we decided to add this tumor immune microenvironment to the project, even though a big bulk of this is to extend the Cancer Genome Atlas project to precancers. And this is happening now in 4 organ sites, and that's actually grown into more organ sites with the Human Tumor Atlas Network. These were the things that we wanted to achieve in our time, and we've done things like doing micro dissection and looking for clonal evolution within the precancers, the DCIS lesions, using gene expression profiles to evaluate the immune landscape sort of in bulk, in addition to doing our immune multiplex immunofluorescence. And you can see that those Tregs are coming up again. Tregs have a high association with recurrence, sort of irrespective of other things in the histology, the intrinsic subtype or the grade of the lesion, etc. Going back to the mouse, we've modeled this in a mouse, and here in this case we serendipitously discovered that this STAT1 knockout mouse developed very late in life, greater than a year old, which for a mouse is very old. It's like being a 70-year-old human. Developed these precancers, followed by inflammation and followed by invasive carcinoma. And I won't go through all the details. You can look at this paper if you're interested. But one of the things that we were very surprised at is if we looked at the conditioned media from these cells, the cells themselves are elaborating factors which are either in the extracellular vesicle fraction, and this is seen in the graph I all the way at the right. The green is the extracellular vesicle fraction. The red is the soluble fraction. And so in the extracellular vesicle fraction, they're increasing macrophage migration. In the soluble fraction, and this is seen in the competition experiments in part H, you can see that they're actually preventing the macrophage migration. So the tumor cells themselves are both calling out to the immune cells and preventing the immune cells from coming any closer in some cases. And if we could figure out how to have them not prevent the immune cells from attacking, we'd be on our way. So what are some of the clues? So here's some clues related to HER2, and I think HER2 is, a well-known, well-studied oncogene in human breast cancer, and so it's a good place to start. And if you look for immune reaction to the HER2 protein itself, I think that you do find it, and you do find correlations with the CD8 HER2 reactive T cells with outcomes in patients with HER2 positive breast cancer. But we've learned that HER2 comes in multiple isoforms. These isoforms have different implications when it comes to whether or not they have the trastuzumab epitope, but also we decided that we should really model these different isoforms in mice. And this is work done by my colleague at Duke, Josh Schneider. In coding the different isoforms in the mouse, we discovered quite astoundingly that the P95 isoform here depicted as the bottom panels and the magenta color have much more significant infiltrates into the tumor area itself, a much greater immune component, whereas the delta 16 isoform tumors were keeping those macrophages at bay and keeping them out of the tumor regions. In single cell sequence analysis, we can study this in a lot more detail, and we can see the immune recognition differences between the two isoforms at much higher resolution. We looked back at the earliest lesions we could find in these tumors and found very interesting differences in the way that these tumors invade, with the ones with the greater inflammatory component having the most invasion right from the initiation foci. So almost immediately becoming invasive, sort of like those nascent, invasive, lethal, no precancer stage breast cancers I talked about. So we hope that we can reclassify DCIS into those that are true precancers versus those that are indolent disease that we can watch or treat minimally. And maybe we can boost the immune surveillance that the host is already utilizing to prevent those from becoming invasive cancers. So I hope at the end of my talk here, you can see the importance of teamwork. I couldn't have done any of this without all of the collaborators that I work with. They're a terrific crew, and I'll thank them, but not individually. This is the long list. You can see also some of our funding agencies as well as our industry partners who have been invaluable to the process. And so thank you for your time, and I'm happy to take any questions.
Very good.
All right, nobody can speak, so I know they have to post their questions in the chat box if they have any, and anyone who wants to catch up with me by email or some other way, I'm happy to address questions that way as well. Thanks, Cliff.
Yeah, thanks, Sandy. Thanks for a fascinating talk with great examples.
I got it in time somehow.
It's a first. No. So thanks very much, everyone.
All right, enjoy the rest of your meeting. I'll be enjoying it with you. Thanks very much.
Okay. Bye-bye.